And today, our mission is to give you a fast, but also a really thorough and usable understanding of the system that, it basically controls the hydraulic pressure and fluid volume across your entire body.
Or the RAS, as we'll be calling it.
You should think of this system as the body's master plumbing regulator. It's not a simple switch. It's a hormonal cascade. And understanding its complexity is, well, it's fundamental to treating the biggest killers in the modern world.
Things like hypertension, heart failure.
Exactly. And chronic kidney disease, the big ones.
And the drugs that target the RAS, they aren't just important, they are pivotal. They're really the cornerstones of modern cardiovascular therapy. So this dive is custom-tailored for the learner, for you, if you need to know not just what the system does,
but how its failure drives pathology.
And why these medicines, like ACE inhibitors, are so incredibly powerful.
Historically, the story starts surprisingly early. We're talking back in the 19th century. Researchers recognized that extracts from the kidney had this dramatic pressor effect.
Pressor, meaning it raises blood pressure?
Precisely. It raises blood pressure. And they eventually isolated the substance that was initiating this activity, and they named it renin.
Okay, but renin wasn't the pressor agent itself, was it? That's where the whole complexity of the cascade comes in.
That's exactly right. Renin is just the trigger. It took until, I think, the 1940s for researchers to figure out that renin is a protease enzyme. Its whole job is to act on a substrate that's just floating around in the blood.
And that substrate comes from the liver?
Yes, an alpha-2 globulin produced by the liver called angiotensinogen. And this is just the first step in this assembly line that leads to the main effector.
Which is angiotensin II.
The main effector, angiotensin II.
Okay, so let's unpack this assembly line. We're going to trace the path from that initial trigger in the kidney all the way to the final powerful pressure-raising hormone, angiotensin II, and establish exactly where we can interrupt it with drugs. So the whole system is designed to save us, right? To save us from sudden drops in blood pressure or volume. Let's start at step 1, the trigger. Where and why does the kidney decide to release renin?
Okay, so the location is key. It's the juxtaglomerular cells, or JG cells, within the kidney. You can think of these cells as these highly sensitive little monitors.
So they're just watching the blood flow.
They're watching, and they're programmed to detect 3 major physiological threats. And all of them relate back to a loss of volume or pressure.
And what are those 3 SOS signals?
First is a significant loss of sodium chloride, so NaCl loss. The body is losing salt, and where salt goes, water follows.
So dehydration, for example.
Exactly. The second is a general fall in blood volume, which could be from dehydration or maybe bleeding. That reduces the stretch that's detected in the renal afferent arterioles.
The incoming pipes to the kidney.
The incoming pipes. And the third is renal ischemia, which is a fancy way of saying there's just not enough blood flow or perfusion pressure getting to the kidney itself. Renin is released in response to any of these threats.
So renin is the key that starts the engine. Once it's released, what's its immediate action?
That brings us to step 2. Renin acts really swiftly on angiotensinogen. And remember, renin is a protease, so it cuts proteins. It cleaves angiotensinogen to produce it's a biologically inactive 10-amino acid peptide.
And that's angiotensin the node.
That's angiotensin O. This decapeptide is just an intermediate. It's basically just riding around in the circulation, waiting for the real transformation to happen.
Okay, so ANGAS is useless on its own. It needs that molecular equivalent of a final push to become the potent ANG2. And that final push is provided by the very aptly named angiotensin-converting enzyme.
ACE. It's the key switch, step 3. ACE is a dipeptidyl carboxypeptidase.
Which is a total mouthful.
It's a huge mouthful. It just means it's an enzyme that cuts off 2 terminal amino acids from the decay peptide ANG1.
So it turns a 10-amino acid chain into an 8-amino acid chain.
And that simple conversion is what turns inactive ANG-I into the active 8-amino acid peptide and angiotensin II in CHO. And that is the system's primary effector.
So where is this crucial conversion happening most intensely? Is it happening everywhere?
It is, but it's concentrated. ACE is an ectoenzyme. That means it's embedded on the outer surface of cells, specifically the luminal surface of vascular endothelial cells.
The lining of the blood vessels.
The lining of the vessels. And while you find it throughout the body's vasculature, it is present in extremely high concentrations in the pulmonary circulation.
The lungs.
The lungs, and also the renal circulation. So this means that as blood-carrying ANG-I passes through the lungs, the conversion to ANG-UP happens incredibly rapidly and efficiently. It allows for a really fast systemic pressor response.
Okay, so that circulating pathway renin from the kidney, angiotensinogen from the liver, conversion happening mainly in the lungs to make anxiety. That is what we call the extrinsic or circulating RAS. It's the acute alarm system.
Exactly. And because Ang2 is so incredibly potent, I mean, unbelievably potent, we need a way to shut it down quickly once the acute danger has passed.
So how does the body neutralize this highly potent molecule? Does it have a long shelf life?
No, not at all. Ang2 has a very, very short half-life in the circulation. We're talking about 1 minute.
Just a minute.
That's it. It's rapidly broken down by various peptidases, which we just collectively call angiotensinases.
Yeah.
And the first breakdown product, which is formed by aminopeptidase action, is a 7-amino acid peptide called angiotensin III, Ang3.
And is Ang3 biologically relevant, or is it just molecular trash at that point?
Oh, it's definitely relevant. It's not as potent as Ang2, not by a long shot.
Okay.
Ang3 is about 2 to 10 times less potent when it comes to causing vasoconstriction, so it's not much of a squeezer. But, and this is a huge clinical caveat, its ability to stimulate aldosterone secretion from the adrenal cortex is nearly comparable to Ang2. So it still plays a critical role in salt and water conservation.
So it's not a major pressure agent, but it's just as good at telling the body to hold on to salt.
Precisely. And then the breakdown continues from there. Ang3 is further attacked into angiotensin IV, which is a hexapeptide, and then eventually just into inactive fragments. This whole rapid sequence of degradation ensures that the circulating RAS can respond quickly to a crisis.
But doesn't keep the pressure high unnecessarily.
Exactly.
Okay, so here's where it gets really interesting for the learner. We've described the circulating RAS, the system-wide response, but the sources all emphasize this critical distinction. The local, or intrinsic RAS. Why is this local system so crucial for understanding disease?
This is such a key concept. The circulating RAS is a hormonal system. You know, the hormones travel via the bloodstream. They affect distant receptors. The intrinsic RAS, however, is a local regulatory system. Many tissues, we're talking the heart, blood vessels, the brain, kidneys, the adrenal glands, they possess the full enzymatic capacity to synthesize Ang2 and Ang3 right there.
Right inside the cell.
Inside the cell or in the immediate cellular environment.
So a heart cell doesn't just respond to Ang2 coming from the bloodstream. It can actually make its own Ang2 locally.
Yes. And these locally generated peptides, they operate on what we call an autocrine basis.
Meaning it affects the cell that made it.
Or paracrine basis.
Affecting its neighbors.
Exactly. And while they contribute to normal local function, their activity profoundly reflects the pathological status.
Yeah.
So, for example, the intrinsic RAS in the kidney can be overactive because of diabetes or hypertension, and that local overactivity is what directly drives hypertrophy, cell proliferation, apoptosis, and critically fibrosis.
Wow, that's a huge distinction.
Yeah.
So the extrinsic RAS is the acute pressure valve, but the intrinsic RAS is more like the long-term chronic remodeling switch that drives that irreversible tissue damage. If you're a doctor treating heart failure, you have to worry about both.
You absolutely have to. And if we're connecting this to the bigger picture of chronic damage, we have to talk about the prorenin receptor system, the PRR system. It's a newer, maybe less understood layer that explains some of the pathological activity that goes beyond just simple ACE conversion.
Okay, so prorenin, that's the inactive precursor to active renin. Traditionally, you think of precursors as just waiting to be activated. How does prorenin, in its supposedly inactive form, get involved in damaging tissues?
Well, prorenin is synthesized in those JG cells, and it actually circulates at 5 to 10 times the concentration of active renin.
5 to 10 times higher.
Yeah. And for a long time, it was considered inactive, but we now know it is biologically active when it binds to this transmembrane protein called the prorenin receptor, PRR.
So just the act of binding activates it, even without the typical cleavage process that would normally make active renin.
That's it. The PRR mechanism is powerful. When prorenin, or even active renin, binds to the PRR, it causes a conformational change that dramatically boosts its catalytic activity. This receptor-bound prorenin can then be activated non-enzymatically by something like cathepsin B or enzymatically by proconvertase 1, and this binding kicks off two distinct and highly damaging pathways.
Okay, let's break those down. Let's call the first one the physical delivery pathway, the Ang2-dependent route.
Right, so in the Ang2-dependent pathway, the renin, or prorenin, that's bound to the PRR, it acts exactly like circulating renin. It converts angiotensin to first to angiotensin II right there locally. That Ang2 then acts on the traditional AT receptors, driving localized cell growth, inflammation, and cell death. It's basically localized high pressure.
Okay, now what about the Ang2 independent pathway? This is the one that bypasses the receptor and sounds particularly sinister for chronic disease.
This is where the PRR shows its really unique pathological influence. The Ang2 independent pathway doesn't need angiotensin II to act on the cell surface. Instead, the binding of prorenin, or renin, to the PRR triggers a direct intracellular signaling cascade.
So it's like an internal email rather than a physical message delivered to the outside of the cell.
Perfect analogy. And what are the pathological pathways this internal signaling activates? Well, it directly activates three major pathways linked to chronic injury. The MAP kinase pathway, PAI1, that's plasminogen activator inhibitor 1, and the JAK-STAT pathway.
And these are the chemical switches that lead directly to cell growth, fibrosis, and organ damage in all crucial areas.
Yeah.
The myocardium, the vascular walls, the kidneys,
Nephropathy.
and the retina.
Retinopathy, yes.
That is critical. I mean, it means damage can be happening through this PRR signaling even if we successfully block angiotensin II at the receptor level. The system is still creating pathology right at its foundation.
And this isn't just theory. We have a clear pathological link here, especially in metabolic disease. The sources point out that the ratio of circulating prorenin to active renin is markedly elevated in diabetic patients. This excessive prorenin, acting through the PRR, is strongly suspected to be a key causative factor in accelerated diabetic nephropathy and retinopathy, all due to RAS overactivity.
Wow. This complexity just underscores why targeting the RAS is such a nuanced battlefield. We aren't just trying to lower pressure, we're trying to stop a chronic, relentless drive toward tissue destruction, driven by both circulating hormones and these local signaling mechanisms like the PRR. So angiotensin II is the molecule that determines whether the body retains fluid and increases pressure. Let's dedicate some time to detailing its system-wide effects, starting with the most immediate, the cardiovascular system.
Right. Its primary acute action is profound vasoconstriction. Ang2 is an incredibly powerful pressor agent. To give you some context, it's about 40 times more potent than norepinephrine. 40 times more potent than NA as a pure pressor agent. It causes direct, smooth muscle contraction in both the arterioles, which are the resistance vessels, and the venules, the capacitance vessels. This immediate squeezing leads to a rapid increase in total peripheral resistance, or TPR.
And therefore, a big, significant rise in blood pressure.
It's a very significant rise.
40 times more potent. That is an immense level of power to hand to a single hormone, which is why that tight regulation we talked about is so key. Does it work alone? Or does it, piggyback on other systems?
Oh, it absolutely enhances the sympathetic nervous system. It works in synergy with the fight-or-flight response. It enhances sympathetic activity both centrally by acting on the brain and peripherally.
How does it do that peripherally?
It increases the release of norepinephrine from nerve endings, and it also augments the output of adrenaline from the adrenal medulla.
So it's not just squeezing the pipes itself, it's also turning up the volume dial on the sympathetic system that already runs the pipes. It's a powerful amplifier.
A very effective one. And regarding the heart itself, Ang2 increases the force of myocardial contraction, and through that sympathetic enhancement, it can increase heart rate.
But you don't always see the heart rate go up.
You often don't. Because the rise in blood pressure is usually so sharp, that direct rate increase is often masked by the baroreceptor reflex, which usually slows the heart rate down to compensate for that sudden pressure spike.
Okay, let's pivot from the acute action to the chronic damage. We established that Ang2 is a chronic disease driver. How does it physically remodel the heart and the vessels over time?
This is a crucial point for the learner. Chronic, elevated exposure to Ang2 makes it act as a growth factor. It stimulates hypertrophy, that's the abnormal enlargement and proliferation, the increased number of myocardial cells and vascular smooth muscle cells.
And this process leads to?
It leads to vessel wall thickening, ventricular hypertrophy, and the accumulation of scar tissue or fibrosis.
What does that fibrosis actually do to the organs? How does it hurt them?
In the heart, fibrosis stiffens the ventricular walls. This prevents proper relaxation, and that can eventually lead to diastolic heart failure, or what we call heart failure with preserved ejection fraction. After a heart attack, an MI, Ang2 accelerates this detrimental ventricular remodeling, causing the non-infarcted areas to hypertrophy and the scar tissue to expand.
And these are the structural changes that are the underlying reasons why chronic RAS overactivity leads to major cardiovascular risk and, ultimately, failure.
That's it. Ang2 is acutely life-saving, but it is chronically organ-destroying.
Okay, so moving to the endocrine system, what's its primary target in the adrenal glands?
Ang2 and also Ang3 are the most potent stimulators of the adrenal cortex, specifically the zona glomerulosa.
And that triggers the release of.
Aldosterone. Aldosterone then becomes the final chemical mediator of salt and water retention in the kidney.
Which brings us directly to the kidney itself. What are Ang2's direct actions there, separate from what aldosterone does?
Ang2 has two key direct actions in the kidney. First, it promotes Na++ exchange in the proximal tubule, which increases the reabsorption of sodium, chloride, and bicarbonate. It's a direct mechanism for volume expansion.
And the second action.
The second, and I'd say most mechanically important, is its action on renal blood flow. Ang2 strongly, almost selectively, constricts the glomerular efferent vessels.
So the small arteries leading away from the glomerulus.
Exactly, the outgoing vessel.
Why is constricting the outgoing vessel so critical? What does that achieve?
Well, think of the glomerulus as a hose with a clamp on the outlet. By clamping that outgoing efferent vessel, Ang2 dramatically increases the hydraulic pressure within the filtration unit. This intrarenal hemodynamic effect, it helps to preserve the glomerular filtration rate, the GFR, even when systemic blood pressure is low.
So it makes sure the kidney can still filter waste and retain necessary volume during a crisis.
It's a clever, immediate compensatory mechanism.
But that sounds like a double-edged sword, because if we use a drug to block Ang2, we lose that compensatory mechanism.
It is the ultimate double-edged sword, and it raises a really important question that we have to address when we discuss therapeutics. If a patient is dehydrated or has pre-existing kidney problems, removing Ang2's compensatory vasoconstriction can cause their GFR to just plummet, leading to acute renal failure. This mechanism is absolutely central to understanding the contraindications of ACE inhibitors and ARBs.
Right. We've covered the periphery, the adrenals. Does Ang2 also exert influence on the central nervous system?
It does. Now, Ang2 is a large peptide, so it normally doesn't cross the blood-brain barrier very easily, but it can access specific periventricular areas of the brain that lack a true barrier.
And what does it do in those areas?
In these regions, it influences thirst, so it increases drinking behavior. It stimulates the release of antidiuretic hormone, or ADH, which further encourages water retention. And it increases central sympathetic outflow. All three of these effects contribute to the overall pressor response.
So, Ang2 is an absolute tyrant. It commands the entire body to conserve water, raise pressure, and promote cellular growth. Now, how does it communicate this message to the cells?
It communicates through receptors, specifically G-protein-coupled receptors, or GPCRs. And there are two primary subtypes, AT1 and AT2.
Okay, so which one is responsible for all the tyranny and pathology we've been talking about?
The AT1 receptor is the primary driver of disease and therefore the main pharmacological target. It mediates all of the major negative effects we've discussed: the vasoconstriction, aldosterone release, growth stimulation, fibrosis, and sympathetic enhancement.
It's the bad guy.
It's a bad guy.
And the AT2 receptor, is it just neutral or does it do something else?
Not quite neutral. It's generally seen as an opponent of AT1. AT2 is associated with protective functions, things like vasodilation, inhibition of cell growth, promotion of apoptosis. The focus of drug development, however, remains squarely on blocking the destructive AT1 activity.
Got it. Understanding that AT1 is the target receptor sets the stage perfectly for the drug classes that have, completely revolutionized cardiology. Okay, ACE inhibitors. They have saved countless lives since they were introduced. Let's start with the beautiful logic of their mechanism. How does just blocking that one enzyme turn off the whole system?
The mechanism is, you're right, it's conceptually straightforward. ACEIs are competitive antagonists of the angiotensin-converting enzyme. By binding to and inhibiting ACE, they prevent that final crucial step, the conversion of Ang1 to active Ang2. So lower Ang2 means lower vasoconstriction, lower aldosterone, and less of that chronic remodeling.
But as we mentioned earlier, the ACE enzyme has a dual role, doesn't it? It's not just an Ang2 manufacturer, it's also a degradation enzyme for other things. And this dual role is the source of both therapeutic benefit and the drug's most common side effects.
This is the crucial secondary mechanism. ACE is identical to an enzyme called kinase II, and kinase II's job is to degrade other bioactive peptides, most notably bradykinin.
And bradykinin is a vasodilator.
It's a potent natural vasodilator, and it also promotes the synthesis of prostaglandins, which also relax blood vessels.
So by blocking ACE, you get a double whammy. Ang2 levels drop, which lowers pressure, but bradykinin levels rise, which also lowers pressure.
Precisely. And the accumulation of bradykinin is responsible for two very distinct things. One, contributing significantly to the overall antihypertensive effect, and 2, unfortunately, causing the persistent dry cough and that rare but serious side effect of angioedema.
Let's talk about captopril. That was the prototype that launched this entire class back in 1977.
The history of captopril is fascinating. Its discovery was heavily influenced by research into the venom of the Brazilian pit viper, the Bothrops jararaca.
Snake venom.
Snake venom. Components in the venom were found to potentiate the effects of bradykinin, which meant they were blocking the enzyme that usually breaks bradykinin down, and that enzyme turned out to be ACE, or kinase II.
That's incredible. A drug class that saved millions of lives, traced all the way back to snake venom.
It's amazing. Captopril was the first orally active ACEI developed from this research. It's a sulfhydryl-containing bipeptide analog. It absorbs reasonably well, about 70% orally, although food can interfere with its absorption. Clinically, it has a short half-life of about 2 hours.
So you have to take it multiple times a day.
Yes, its effects only last 6 to 12 hours. Newer ACEIs like enalapril or lisinopril have much longer half-lives, which allows for once-daily dosing. But captopril is still the foundational drug.
Now, let's detail the profound positive effects. Starting with hypertension, how do ACE inhibitors stack up?
They are first-line therapy for virtually all grades of hypertension. They reduce total peripheral resistance through vasodilation, but unlike some older drugs, they typically do not cause reflex tachycardia, which makes them generally very well tolerated. They lower both systolic and diastolic blood pressure. And beyond just the numbers, large trials confirm they reduce long-term cardiovascular morbidity.
They improve quality of life as well, right?
Yes, particularly regarding issues like sleep and sexual function, especially when compared to some of the older antihypertensives.
And their role in congestive heart failure, CHF, is equally, if not more, important.
In CHF, the heart is struggling to pump effectively. ACEIs provide 2 critical benefits here. They cause arterial dilation, which reduces the afterload. That's the resistance the heart has to push against.
Makes the heart's job easier.
Much easier. And they also cause venular dilation, which reduces preload, the volume of blood returning to the heart. This dual reduction in cardiac work dramatically increases the cardiac output.
And what's the evidence of their impact on survival in heart failure patients?
It's significant. ACEIs delay the progression of systolic dysfunction, and they have been shown to reduce mortality in symptomatic CHF patients by approximately 20%. This isn't just symptom management, this is life extension through preventing that detrimental remodeling.
Okay, moving on to acute events, myocardial infarction and MI. How do ACEIs prevent damage after a heart attack?
As soon as a portion of the heart dies from an MI, the RAS system in the heart tissue activates. It goes into overdrive, driving that remodeling hypertrophy and fibrosis in the remaining healthy muscle. This leads to ventricular dilatation and eventual failure.
So the ACEIs stop that process.
They interrupt this local RAS activation, they prevent this progressive remodeling, and they're used in stable angina, NSTEMI, and STEMI patients after reperfusion. They offer crucial long-term survival benefits regardless of the initial heart function.
So they are not just useful for treating existing damage, they are powerful, protective, and prophylactic tools.
Absolutely. The prophylactic use was cemented by trials like the HOPE trial. This was a massive study, and it demonstrated that in high-risk patients like those with diabetes, existing vascular disease, or a history of an MI, even if they did not yet have left ventricular dysfunction.
So before they had heart failure.
Before they had heart failure. Prolonged ACE inhibitor therapy reduced the risk of developing heart failure, having another MI, or having a stroke by a stunning 22% over 4 to 5 years. It's like a preventative shield against a future cardiovascular catastrophe.
And finally, their profound benefit in kidney disease, especially when it's linked to diabetes.
This is one of their most specific and powerful uses. Prolonged ACE inhibition delays the progression to end-stage renal disease in both type I and type 2 diabetes. And they achieve this primarily by lowering the pressure within the glomerulus. Remember how Ang2 constricts the efferent arteriole?
Yes, the clamp on the outgoing vessel.
ACE inhibitors remove that clamp. By dilating the efferent vessel, they reduce the internal pressure on the glomerulus, which slows the rate of damage to the kidney's filtration mechanism.
And you can measure that benefit, right?
You can. This action translates clinically into reducing proteinuria, or albuminuria, and stabilizing overall renal function. It even helps retard the progression of diabetic retinopathy.
That is an astonishing list of benefits across nearly every major cardiovascular domain. But we have to turn to the trade-offs, particularly the adverse effects that cause so many patients to stop treatment.
The most common and frankly frustrating side effect is the persistent dry cough. It affects somewhere between 10 and 16% of patients. It's non-productive, it's irritating, and it is the single most frequent reason people discontinue the drug.
And this ties back directly to that bradykinin accumulation we discussed.
Correct. The elevated bradykinin and substance P in the lungs irritate the airway receptors. The cough typically appears within weeks of starting the drug, and critically, it always subsides 4 to 6 days after stopping the drug. This is the main reason why the next drug class we'll discuss, the ARBs, was even invented.
Okay, what about the more dangerous side effects?
The most serious is angioedema. This is the swelling of the face, lips, tongue, or throat. It's rare, occurring in 1 to 4% of patients, but it is life-threatening because it can obstruct the airway. And like the cough, it's caused by bradykinin accumulation and requires immediate discontinuation of the drug.
Let's discuss the critical monitoring that's required, particularly for electrolytes.
Hyperkalemia, or elevated potassium, is a genuine risk. Since ACEIs reduce Ang2, they consequently reduce aldosterone. And because aldosterone normally promotes potassium excretion, lower aldosterone means the body holds on to potassium. The risk is highest in patients with pre-existing renal impairment or those taking potassium-sparing diuretics. This means you have to do careful blood monitoring.
And let's reemphasize the renal danger. Acute renal failure.
This is an absolute contraindication in specific cases. Acute renal failure can occur in patients who have bilateral renal artery stenosis.
Meaning both of their kidney arteries are severely narrowed.
Exactly. These kidneys are completely reliant on Ang2-mediated efferent constriction to maintain their GFR. If you administer an ACEI, that efferent arteriole dilates, GFR falls drastically, and the patient goes into acute renal failure. This must always be ruled out in susceptible patients.
And finally, the critical warning regarding pregnancy.
Yes. ACE inhibitors are highly fetopathic. They are teratogenic if used during the second half of pregnancy. They can cause severe fetal growth retardation and hypoplasia of developing organs. They must be avoided completely in pregnancy.
That intensive analysis of ACEIs provides a clear mandate, doesn't it? We need a drug that provides all that cardiovascular protection without the side effects driven by bradykinin accumulation. And that leads us directly to the ARBs.
Angiotensin receptor blockers, or ARBs, represent the next generation of RAS blockade. They offer a fundamentally different, and I'd argue a cleaner, way to shut down Ang-C's message. They're the ideal alternative for that 10 to 16% of patients who just cannot tolerate the ACEI cough.
So how do ARBs differ mechanically from ACEIs? It's a different target.
A completely different target. ARBs are non-peptide, orally active compounds that selectively block the angiotensin II AT1 receptors. So unlike ACEIs, they don't block the enzyme that creates Ang2, they block the doorbell that Ang2 tries to ring. They're inverse agonists, so they silence the receptor and prevent vasoconstriction, remodeling, and aldosterone release right at the target cell level.
Which means they bypass the entire bradykinin problem.
Precisely. Because ARBs do not interact with ACE, which is kinase II, they leave the degradation of bradykinin completely intact. This results in a dramatically lower incidence of cough and essentially eliminates the risk of drug-induced angioedema when compared to ACEIs. That is their primary clinical advantage.
Now, you mentioned an interesting pharmacological difference that stems from their downstream action. The blockade causes a sort of compensatory response to the cascade.
It does. When the AT1 receptor is blocked, the negative feedback loop that normally suppresses renin release is removed. The result is a compensatory, dose-dependent increase in the levels of renin, angiotensin I, and even angiotensin II itself. Ang2 levels can rise quite substantially in the blood.
But if Ang2 levels are higher, why isn't the patient sicker? That sounds counterintuitive.
It does, but it's because the Ang2 can't act on its destructive primary target, the AT1 receptor. That door is locked. Instead, the excess Ang2 is free to stimulate the unblocked AT2 receptors.
The good guy receptors we mentioned earlier.
Exactly. And since AT2 is associated with protective effects, vasodilation, and anti-proliferation, this compensatory action may actually contribute to the overall beneficial profile of ARBs. Though I should say this effect is still highly debated in clinical pharmacology.
Let's look at some of the key drugs in this class. Losartan is the foundational example, correct? Losartan is the prototype. It's a competitive antagonist, meaning it competes directly with Ang2 for the receptor site. It has remarkable selectivity for AT1, about 10,000 times greater than for AT2. Pharmacologically, losartan's bioavailability is only about 33% because of first-pass metabolism, but it generates a highly active metabolite.
And it's the metabolite that does most of the heavy lifting.
That would be E3174. E3174 is 10 to 30 times more potent than losartan itself, and it ensures a sustained blockade, which compensates for losartan's relatively rapid breakdown.
And what about the other key players in the class? Do they have different characteristics?
We see varied pharmacokinetics across the class, which is useful. Candesartan, for instance, has the highest affinity for the AT1 receptor, and it achieves what we call unsurmountable antagonism. That means no amount of Ang2 can overcome its blockade.
It's a much stronger lock. A much stronger lock. Then you have drugs like telmisartan, which is noted for its extremely high affinity and a very long half-life of 24 hours. That makes it excellent for consistent once-daily dosing. Other key examples include valsartan, irbesartan, and olmesartan. They all demonstrate a similar broad clinical utility for hypertension, CHF, and diabetic nephropathy.
So ARBs offer similar clinical outcomes to ACEIs in their primary uses, but with this massive advantage in patient tolerability because of the lack of cough and angioedema risk?
Absolutely. They are the preferred choice when an ACEI cannot be tolerated or when a patient develops that characteristic bradykinin-driven side effect.
Okay, now let's pivot to the newest class aimed at the RAS, the direct renin inhibitors, or DRIs. These target the cascade right at the very start.
DRIs, with the main example being aliskiren, are the newest non-peptide drugs. Their mechanism is designed to shut down the RAS before it even begins. They bind selectively and very tightly to the catalytic site of the renin enzyme itself in the kidney.
So if they bind to renin, they are physically preventing that first step from ever occurring.
That's right. By occupying renin's active site, they effectively block the access of angiotensinogen. No renin-angiotensinogen interaction means no Ang-I production, and so the entire cascade is silenced right at the top.
What are the physiological effects of blocking renin directly?
You see a comprehensive dose-dependent decrease in Ang-HERs, Ang2, and aldosterone. Interestingly, like the ARBs, blocking the system causes that negative feedback mechanism to kick in, which results in a strong increase in plasma renin activity, or PRA. But crucially, because the renin is chemically bound and inhibited by aliskiren, the cascade remains interrupted despite the high PRA levels.
Are DRIs currently replacing ACEIs and ARBs in practice?
Not yet. They are recommended as an alternative antihypertensive therapy for people who can't tolerate or don't respond adequately to the other classes. Clinically, they produce antihypertensive effects that are similar to ACEIs and ARBs. However, their long-term value, especially regarding mortality reduction and cost effectiveness compared to the proven, decades-long track records of ACEIs and ARBs, is still under broader assessment.
This brings us to a pharmacologist's dream scenario. What if we combine therapies? The theoretical benefit of combining an ACEI and an ARB seems immense. You reduce production and you block the receptor simultaneously.
The rationale for dual blockade is compelling, on paper. By combining an ACEI and an ARB, you attack the system at two separate points. The ACEI reduces the circulating Ang2 production, and the ARB blocks the AT1 receptor, catching any Ang2 that might be generated through alternative non-ACE pathways.
Like chymase, which can also make Ang2.
Exactly, like chymase. So the goal is total RAS suppression.
Has this proven superior in clinical practice?
Well, dual blockade has shown clear additive hemodynamic and symptomatic improvements over monotherapy, particularly in conditions like advanced CHF and diabetic nephropathy. The idea is that you can achieve a superior ceiling effect in managing the disease.
But in clinical trials, the big ones, seem to paint a more cautious picture, especially regarding long-term hard endpoints like mortality.
That is the critical controversy. Randomized trials such as Valiant, Charm Additive, and Cooperate have all yielded mixed results. While a trial like Cooperate suggested benefits in non-diabetic renal disease, the overarching concern is safety.
What are the specific safety risks that make clinicians so wary of combination therapy?
When you hit the RAS system that hard from two directions, the risk of severe adverse effects increases significantly. Clinicians observe elevated rates of severe hypotension, dangerous hyperkalemia, and acute renal impairment.
So the risks start to outweigh the benefits.
In many large population subsets, yes. The incremental benefit in reducing mortality simply did not outweigh the elevated risk of these severe side effects.
So the current consensus is not total dual blockade for everyone?
No, absolutely not. The current consensus is strongly against routine dual blockade. We reserve that combination for highly specific resistant cases, often in specialized heart failure clinics, where the benefits clearly justify the intensive monitoring and the elevated risk. For most patients, achieving blockade through a single pathway, maybe combined with a difficult class of drug like a beta blocker, is the safer and proven strategy.
That distinction between pharmacological theory and clinical reality is such key knowledge for the learner. Hashtag tag outro. So what does this all mean? We've traced the renin-angiotensin system from the kidney's first crisis signal all the way through its cascade, culminating in angiotensin II, this potent hormone that functions both as an acute lifesaver and, well, a chronic disease driver.
And the key takeaway, I think, is the sophisticated hierarchy of targeting this system. We learned that the destructive power of the system lies in that AT1 receptor and also in the local PRR signaling pathways, which are what drive that irreversible organ damage. Targeting this system lets us treat and prevent major cardiovascular disease.
And the distinction between the therapies is based entirely on where they intervene in that cascade.
Exactly. ACE inhibitors hit the enzyme, blocking production but causing those bradykinin side effects like cough and angioedema. ARBs hit the receptor, avoiding the bradykinin issue, and maybe even allowing some beneficial effects through the unblocked AT2 receptor. And then the direct renin inhibitors, like eliskerin, represent that elegant start of the cascade block, though their long-term clinical role is still evolving.
You know, the discovery of ACE inhibitors after identifying the conversion enzyme led to these massive breakthroughs in cardiovascular survival rates.
Yeah.
We have focused so extensively on the angiotensin II pathway, but the cascade continues to break down into other fragments.
Indeed. We mentioned the degradation process leads to molecules like angiotensin 1-7, which is a heptapeptide that generally has opposing protective effects. It causes vasodilation, it's anti-proliferative and anti-fibrotic.
So this raises the final provocative thought for our listener. If the body already possesses its own internal good peptides that counteract angiotensin II, what will the next generation of drug targets look like? Will we move beyond simply blocking the bad components and instead focus on enhancing the activity or the stability of protective angiotensin fragments like angio 1-7?
To achieve organ protection without all the systemic pressure changes or side effects of a broad RAS blockade, that is the exciting frontier. We may soon see drugs designed not to silence the system, but to selectively amplify the good messengers, unlocking a whole new level of precision therapy for chronic heart and kidney disease.
Something for you to mull over until our next deep dive.